Another regimen is Procrit. That helps stimulate the red blood cell production. It's usually effective also about 30 to 45 days ahead of time, but at least 3 weeks. Certain insurances will pay for this, not all of them do. It's a pretty costly intervention, so unless we absolutely have to do it, we normally don't go that route, but the ones that are optimized with that are the patients between 10 and 13. So we can kind of help build that up significantly over about 3 weeks. Autologous donation used to be done all the time. When I was in my training 10, 12, 15 years ago, everybody had to donate 1 or 2 units of blood before surgery. And then we kind of went on the premise that we would just turn around and give this back to them after surgery. The problem is obvious. You rob Peter to pay Paul, in that you are taking blood out of your body that oftentimes your body does not have the time or the ability to restore that back up to optimal levels before you undergo the procedure. Oftentimes also you would not need to give that blood back, so you would end up wasting a lot of that blood. I told you how much that costs, and so it was a pretty significant thing. I haven't really asked my patients to do autologous donation for probably 8 or 9 years. And that's kind of the trend that is taking place. It's not done very much. I did have one patient, though, and it's actually the only unit of blood that we've transfused this year to date. I had a lady that came in. She was scheduled for hip replacement. She shows up on the day of surgery, and she tells me, "Hey, I donated my own blood." And I'm like, I didn't ask you to do that. She goes, "I know. I just read about it and thought it would be a good thing." And so we did give her blood back, and she was very happy. But it's not a normal thing that we do. When the next step that we go to is intraoperative. Obviously, during surgery, it's critical for things to be managed and blood to be managed. That's when we have that. That's when we're in the trenches, so to speak, and so we can do the best job we can to minimize blood loss. Certain things we try to do is gentle soft tissue techniques. Now, I don't want you to think that we go in and slice and dice and hack and things, but there are certain ways that we can do things more gentle and more cautious and more aware of what we are doing to the soft tissues, the muscles, the tendons, the bone, and so forth and so on. We use muscle-sparing approaches and minimally invasive techniques. These have really the last few years have made a huge difference in orthopedic surgery. We use different types of electrocautery and shrinking devices, tissue shrinking devices, that help control bleeding intraoperatively. And we also use hypotensive anesthesia in some respects, which includes regional anesthetics like spinals, or keeping the patient's blood pressure down to a certain level so that they do not bleed as much. Pharmacological things that we use during surgery. These have really come into vogue the last few years, and there's some great data out there. And I've seen great results in my own practice with this. Some things that help the clotting process, help prevent the breaking down of the clot, and that's what an antifibrinolytic is used for. We have things called tranexamic acid and aminocaproic acid, or Amicar, other types of things that help control bleeding in surgery, and you can give those both intravenously and also topically in the wound. We have different things like fibrin sealants. Orthopedic surgeons don't use that quite as much as general surgeons and so forth, but sometimes they're utilized and effective. Local anesthetics. We've heard about epinephrine by Dr. Worthington. We also use types of anesthetics that has epinephrine in it, and thus it helps decrease blood loss. Acute normovolemic hemodilution, it's not used very much. It's kind of a fancy thing. I'm not going to spend the time on it, but it's utilized when in a procedure you have to that you're planning on having a significant blood loss, like a cardiac surgery or something. In orthopedics, we normally don't use that. Blood salvage procedures, such as things called cell saver. That is where we actually take blood from a suction device in surgery, and we turn around and filter it, and then give a portion or percentage of that back to the patient, either intraoperatively or immediately postoperatively. It's good if you're going to lose a lot of blood, but if you think about it, it's never as good as not losing the blood in the first place. When you filter that blood, it does damage blood cells. They do not work as effectively, and you're usually not able to give back nearly as much as what is taken out. We use tourniquets for the extremities. There's a certain time limit that tourniquets are incredibly safe. Obviously, you want to work very efficiently and effectively with that. And the biggest thing to help control blood loss is to decrease your operative time or your surgical time. The less time that you have that patient exposed to bleeding, the less blood loss you're going to have. And so we work very efficiently and very proficiently on trying to minimize the operative time. Postoperatively, there's just a couple of things that we do. There's postoperative drainage and reinfusion systems, similar to cell saver, but they're a drain that you'll have in your knee or your hip that will continue to drain the blood from the time of surgery, and then you can go ahead and give some of that back postoperatively in the next couple of days. Certain types of splinting help rest the wound, and careful anticoagulation and VTE prophylaxis, that's like DVT and pulmonary embolism prophylaxis. We constantly fight with the hospitalists and the internal medicine doctors on this. They want us to aggressively anticoagulate, which thins out the blood tremendously, but that also leads to more bleeding, potential wound complications. So they're always concerned about preventing the DVT and the blood clots, where we're concerned about the blood loss and potential wound complications and other infections. So we kind of have to walk a fine line and a balance with that. Our experience here, this is not based on a lot of scientific stuff, but it is based on real-life clinical things that we have seen in my own practice and in our own practice. Preoperatively, we do use the vitamin supplementation. We recommend that. We have them follow up with their primary care physician, their internist, and we encourage that and to resolve the anemia before they go into surgery. If we need to, we will initiate Procrit to help build that back up, especially if someone is adverse to having a potential transfusion for religious purposes or other reasons, and they are marginal on their hemoglobin. We want to build that up as much as we can. Obviously, we limit our surgical candidates to stay below a BMI or a body mass index of less than 38 to 40. 38 to 40 is pretty large. The bigger the patient, the more soft tissue that you have to deal with, the more bleeding that you have, and the harder it is to control the bleeding. So it's important to keep your surgical candidates at an optimal level the best we can. Obviously, that's not always possible, but we do the best we can. I do not recommend bilateral replacements on bilateral hips or knees. I've done both and done it a few times, but I do not encourage it. Obviously, it's common sense to say you're going to have double the blood loss, double the operative time, double the anesthesia, double everything else, double the potential. So we try to steer people away from that and do one at a time, give at least 3 months in between the procedures to help build the anemia back up and the blood loss. We get preoperative medical and cardiac clearance and the preoperative lab work. Obviously, we try to use the minimally invasive and the gentle techniques the best we can. There's a new technique, I'm sure many of you have heard of it. It's called the anterior hip replacement. It's accessing the hip from a different angle. You're basically not detaching muscle or going directly into muscle, but you're actually gently moving muscle out of the way so you can get down to the hip joint. This helps decrease your blood loss, and it's much better for the patients. They seem to do much better afterwards. We use hypotensive anesthesia, both spinal and other things. We use both tranexamic acid and the Amicar. This is a very inexpensive way to help decrease the blood loss. We also use tourniquets and decreased operative time on a total knee replacement. Our tourniquet times are usually around 40 minutes, 40 to 45 minutes, so we get in there, get it done, do it right, and get out. By doing that, we minimize that blood loss and have had great effect. And also we use local anesthetics with epinephrine. We use basically an aspirin 2 times a day for our DVT prophylaxis, and we will use other methods as well if somebody is at higher risk. And we aggressively get them up with physical therapy to help avoid blood clots and so forth, and to avoid a lot of the other complications that we have. We have narrowed our stay down actually less than this. For an average of total hip replacement, they're usually in the hospital on average of about 2.2 days, and total knees about 3 days. Now we are getting some patients out to the next day, and there's even a trend to outpatient hip replacement. So it's pretty amazing on kind of how we keep pushing the envelope. You still have to step back and evaluate things on a data perspective, on an evidence-based standpoint. But we've had huge success. In 2014, my practice, I transfused approximately 4 units of blood. That's not only including the about 150 hip and knee replacements that we did. Actually, I believe we only had to transfuse 1 unit of blood in all of those hip replacements and knee replacements. But I also take orthopedic trauma call for YRMC, and this includes femur fractures and hip fractures and other things that are going to bleed a substantial amount, and that's why those other 3 units were there. So we've done pretty well. It was funny, when I was preparing this, I saw a van out there on the American Red Cross. Nothing to ditch about them. Obviously, they do heroic work, and it is necessary sometimes we are all, potentially might need a transfusion sometime if we're in a bad situation. But is it more habitual or is it more heroic? I want you to think of that. And I think a lot of it are habits that we have been practicing that I think that we can trend away from and avoid that, and it will help everybody involved. Thank you. Appreciate it.